Assalamu alaikum. In continuation of the previous voice notes or presentation on CA prostate, let's discuss the various steps of radical open prostatectomy. Is it asked many times in short cases and long cases? So it's important to have a brief review of the surgical technique of the open radical prostatectomy. I'm not going in detail of indication, etc., but I'm straightforward going to the surgical steps. So the pre-op preparation is important by taking proper medical and surgical history of the patient. Then after that, it's important if the patient is having a needle biopsy, better to defer the surgery for 6 to 8 weeks. And if the patient has done transurethral resection of the prostate, I means TRP, then it's better to defer the procedure for 12 weeks. So for trus biopsy, 6 to 8 week, and for TRP 12 week, defer the radical prostatectomy. And the reason is that this delay will enable inflammatory adhesion or hematoma to resolve, so that the anatomic relation between the prostate and the surrounding structure return to normal before surgery. This is especially important if someone is at home having a hope to preserve the neurovascular bundle. It also helps to avoid the rectal injury. So this was the important point which I wanted to edit. Now the patient before the surgery is prescribed a clear liquid diet on the day before the surgery and request to drink 1/2 bottle of magnesium citrate in the evenings and having an enema on the morning of the surgery. Patients are admitted to the hospital one day before with all the labs before the procedure. Now you must having some special instruments in your surgery, like must have a standard Balfour retractor with both narrow and wide malleable blades, because it's useful in node dissection and is also during radical prostatectomy. So you also may need for 2.5 to 4.5 power loops to have a good view and meticulous surgery. Now coming to the anesthesia, incision and lymphadenectomy. Generally it's done under general anesthesia, and for lymph node dissection it is usually having no importance. It's only important for staging, but it having no therapeutic importance. So before going, the patient is placed on the supine position. The table can be placed in obese patient in order to increase the distance between the umbilicus and pubis. The skin is prepped and draped in the usual way. A 16 number catheter is passed into the bladder, and that is inflated with 20 ml of saline, and that is connected with a closed continuous drainage the way we are doing daily. The use of 16 catheter facilitates the placement of suture in the mucosa of the urethra when we incise the urethra. So this small caliber urethra will help at that moment. A right hand surgeon should stand on the left side of the patient. Same is the case for radical cystectomy. So for radical cystectomy and prostatectomy, in both conditions, a right-handed surgeon should always stand on the left side of the patient. And then an incision is given that is extending from the pubis toward the umbilicus. Now let here some modification. For radical cystectomy, we are using the same incision, but we are extended about 2 centimeter above the umbilicus. So for radical prostatectomy, it's from pubis toward the umbilicus, while in radical cystectomy, from pubis 2 centimeter above the umbilicus. And the proper procedure is extraperitoneal. Why? Because the extraperitoneal having a lot of benefits. It's will help you in the recovery of the patient, early recovery of the patient. There will be low risk of the ileus, because there will be less handling of the bowel, and if we know that small bowel is actually happy in the that's fluid volume and that's peritoneal cavity. So this is the reason that much of the surgeon prefer the extraperitoneal approach for radical prostatectomy. and on reaching the bladder, and it's important to take care of the soft tissue covering the external iliac artery that contain the lymphatic drainage. It's all so important if there is a pre-op, there is a large lymph nodes and you want to remove the lymph nodes. So better to perform the pelvic lymph node dissection before the radical prostatectomy. This dissection begins on the ipsilateral side of the major tumor in the possible prostate by dividing the adventitia over the external iliac vein. Now coming to the main steps of the radical prostatectomy. This was also general information pre-op preparation, but now coming to the steps. So the first step was incision. Now the second step is the incision in the endopelvic fascia. In incision, we discussed all the things, that cutting first this layer, then that layer, then that layer. So now we have reached to the interior of the prostate and the red space, where we will be giving and performing the second step, and that is the incision in the endopelvic fascia. What is endopelvic fascia? This is a fibroadipose tissue that covering the prostate, that should be very carefully dissected to expose the pelvic fascia, puboprostatic ligament, and superficial branches of the dorsal vein. So these three important structure is important to expose by giving incision in the endopelvic fascia. We don't want to give in a very minor detail of this incision in the endopelvic fascia. So this was the second step. Now coming to the third step. In third step, we will be performing the division of the puboprostatic ligament. So because it's hold with the pubis in a position, so we want to release from there. So the third step is the division of the puboprostatic ligament. Now the fourth step is the preservation of the accessory pudendal artery. Why we are trying to preserve, and in how percent patient of this accessory pudendal artery is present? The accessory pudendal artery, this is a one additional perineal artery that can present in some cases. It usually arises from the pelvic segment of the internal pudendal artery, which is a branch of the external iliac artery. So this is present in around 70% of the patient. And why we are preserving this accessory pudendal artery? Because this is important if you are trying to prevent the performing the nerve sparing surgery and you want to preserve the erectile function of the patient. So arterial insufficiency can result from injury to the accessory pudendal nerves. And how can we save this? We will save this as it run over the anterolateral surface of the prostate. So our dissection should be meticulous to save this surgery. This was the fifth stage. Now, after the preservation of the accessory pudendal nerve, now the anterior surface is almost free. From above, we have saved the accessory pudendal nerve. Now the sixth step is the ligation and then division of the DVC, dorsal venous plexus. So in this, the goal is to provide complex, to divide the complex with minimal blood loss while avoiding the damage to the striated sphincter and involuntary entry into the anterior apex of the prostate. So this is our intention, to identify and then ligate and divide the dorsal venous plexus. So this was the sixth step. Now coming to the seventh step. The seventh step, it's also important in sixth step during the division of the dorsal venous plexus. It's better to sew the edges of the proximal distal vein because it may bleed later on. So better to suture it with 2-0 Vicryl. Now coming to the seventh step, and that is the division of the urethra and placement of the urethral stitch. The urethra should be divided first in performing a standard nerve release. If more aggressive nerve preservation is performed, the urethral incision should occur after nerve release. So by this we will be taking around 6 distal sutures from the urethra, and that suture should not be very deep to reach into the smooth muscle. So that should only include the mucosa and submucosa, not extending into the smooth muscle. This is the standard technique. After the division of the prostatic and placement of the urethral suture, now it's a time to preserve, if our surgery intention is to preserve the nerve bundle, neurovascular bundle. So at this stage we will first identify the neuromuscular bundle, and then we will preserve and isolate that from our prostate structure. But this decision should be pre-op, to decide that either I will be going for nerve sparing or not. However, much of the time the decision is not properly made, or just during surgery. If you have suspicion and you want to identify the neuromuscular bundle, so this is the area where the tactile sensation provided by open surgery is so important. If there is induration is palpable in the lateral pelvic fascia, the bundle should be excised. Also, in gently releasing the bundle with right angle clamp, if the bundle is fixed to the prostate, it should not be preserved. When the neurovascular bundle is released, there should be there should be no upward traction on the prostate. Rather, the prostate should be rolled from side to side. So this was about the seventh step. Now coming to the eighth step, and that's include the posterior dissection and division of the lateral pedicle. So after preservation of the neuromuscular neurovascular bundle, it's now a time to reach into the posterior aspect of the prostate, release the lateral pedicles, and then go behind the denovular fascia. And the ninth step is the division of the bladder neck and excision of the seminal vesicle. So this excision is carried down to the mucosa. The mucosa is incised, the polyballoon is depleted, and the two ends of the catheter are clamped together to provide traction. As the incision in the bladder neck is widened, branches running from inferior vesicle to the prostate are noted at 5 and 7 o'clock. So at this stage we will be dividing the bladder neck, and we will also perform the seminal vesicle excision. Now the last and the 10th step is the bladder neck reconstruction and anastomosis. Now it's also important to discuss the post-op care and follow-up. For post-op care, traditionally the patient is ambulate in the evening of the prostate procedure, but in our setup we are not mobilizing the patient on same evening but on next day. Pain control can be achieved by either intravenous or oral, and the patient allowed or offered clear fluid on the evening of surgery and regular low fat diet in the next day, and a single closed section drain is left in place until discharge, or it produces less than 50 ml per day of the section. The urinary catheter is placed for around 7 days post-operatively, and if the patient is having some bladder spasm, you can advise him oxybutynin, and then after 10 days follow the patient NOPD, and during follow-up remove the catheter, and then the last is how to follow up this patient. The radical prostatectomy patient is followed by PSA plus DRE at 3 months, 6 months, and 12 months. Then every 6 months until 3 years, and then annual lifelong. And this is same criteria is followed for radiotherapy as a primary procedure.